further action on the cell. So MCT8 and OATPS, these are the gateway for T3 and T4 for further action on the cellular level. Once the T3 and T4 enters at the cellular level, so what they do? First, it is done a conversion of T4 to T3, because T3 is a biologically most active component. So T4 is mainly converted into the T3. So within the target cells, T4 is converted to the more active T3 by one enzyme. This is known as deiodinase enzymes. So primarily type 1 and type 2 deiodinase enzymes are there. Their function is to convert T4 into the T3 at the cellular level. T3 binds to the thyroid hormone receptors in the cell nucleus. In the cell nucleus, there is a specific receptors. They are known as the thyroid hormone receptors, TRs. And T3 binds with these receptors, and this receptor functions as the transcription factor, regulating the expression of specific genes. So specific gene expression is mainly done by T3, while when it combines or binds with the thyroid hormone receptors. Genomic effect. T3 when bound to thyroid receptors and then it again binds to thyroid hormone response elements in the promoter region of the target genes. This binding can either activate or repress transcription depending on the presence of co-activator or co-repressor. Let us understand that in every cell there is specific genes, and on a gene there are specific thyroid hormone response elements. So here there are combination of three things. One is T3, another is thyroid receptor, and third thing is thyroid hormone response element, which is done TRES. So when these three things combines together, they can actually repress or activate the function of genes. Effect of thyroid hormone at the gene level. Thyroid hormone class.
मैं तो नहीं देख
क्लास
मैं से कल यहाँ पे इसी छोड़ूंगा ये आपकी
मैम 1 मिनट
क्लास रूम ठीक तो वो इंश्योर करना ऑफिस खुलेंगे वो आप कर लीजिएगा
ठीक Now the T3 binds to thyroid hormone receptor, which are nuclear receptors. They are present on the nucleus, and these nucleus receptors are of two types: TR alpha, thyroid receptor alpha, and thyroid receptor beta. So the TR alpha are predominantly expressed in the heart, skeletal muscle, and brain, and TR beta are predominantly expressed in liver, kidney, and thyroid gland. स्लाइड चेंज नहीं हो रही कुछ नेटवर्क इश्यू है इसकी वजह से लैगिंग हो रहा है अभी मैम स्लाइड चेंज हो रही है वहां
नहीं सर नहीं हो रही
नहीं हो रही जैसे बाइंडिंग टू न्यूक्लियर रिसेप्टर फॉर्मेशन ऑफ रिसेप्टर कॉम्प्लेक्स दिखाई दे रहा है
नहीं अभी वापस टाइटल स्लाइड ही आ गई सर आप फुल स्क्रीन कीजिए सर फिर चेंज कीजिए सर
क्या
फुल स्क्रीन करके आप चेंज कीजिए प्रेजेंटेशन मोड पे लाके आप चेंज कीजिए अभी तो आपका
वो तो मेरी साइड से मैंने कर लिया है पहले चल ही रहा था लेकिन शायद मुझे लग रहा है
अभी तक आ ही रही थी
हाँ
इतने स्लाइड्स आपने जो एक्सप्लेन किया वो सब आ ही रहा था अभी नहीं आ रहा है बस
हाँ वो एक्चुअली कभी कभी नेटवर्क का कुछ इश्यू हो रहा है, पता नहीं मुझे भी। एक मिनट फिर से मैं कोशिश करता हूँ। डिस्टर्ब कर रहा है ये, बीच में फ्लो डिस्टर्ब कर रहा है। ये आपकी ओर से हो रहा है?
हाँ जी।
ओके। आपके यस, so we were talking about thyroid hormone entry T3, entry of T3 on the nucleus. And on the nucleus, there are specific receptors, thyroid receptors, alpha and thyroid receptors, beta. So this TS, thyroid receptors, bind to thyroid hormone response element, as we have discussed. On the each chromosome, there is a specific thyroid hormone response elements in the promoter region of the target gene. And TS typically function as a heterodimer with the retinoid X receptors. So how they regulate gene transcription, let us discuss without T3. When T3 is not liganded with the gene, so unliganded state of T3 or without T3, what occurs? So in the absence of T3, when there is not T3 on the nucleus, at that time TRs bind to, means thyroid receptor bind to the TRES, thyroid receptor elements on the gene, and recruit co-repressor proteins such as nuclear receptor co-repressor NCOR and silencing mediator for retinoid and thyroid hormones receptor. This condition leads to the suppression of gene transcription. So in this condition, what occurs if T3 is not attached with the thyroid receptor? So there is no any activity which is promoted by the T3. This is simplest. Next, yes, when T3 is binded or liganded with the thyroid receptors, so what occurs? It induces a conformational change and it leads to the release of co-repressor and the recruitment of co-activator protein such as steroid receptor co-activator 1, SRC1 and P300 CBP. This condition promote the assembly of the transcriptional machinery and activate gene transcription. So ultimate message of this thing is that when P3 is uh, in the liganded state and binded with the thyroid receptor, so it produces the some specific proteins with the help of the particular genes for metabolism of the cell. Next, now at the target gene, what physiology occurs? Mainly the when genes are activated. So when metabolic genes are activated, then what they do? Sodium, potassium ATPases, they increase cellular level ATP consumption and they boost the basal metabolic rate. So when thyroid hormone T3 uh, is liganded with the specific genes, they increase the cellular ATP consumption and boost the basal metabolic rate. It also increases thermogenesis, contributing the heat production. They enhance the gluconeogenesis in the liver and increase the blood glucose level. Also, the gene promote the lipolysis and fatty acid oxidation. So this is the mainly due to the activation of the target genes, mainly metabolic genes. Next, when developmental and growth genes are activated by the thyroid hormones, then it stimulates the growth hormone synthesis and secretion. It also increase the myelin basic protein, which is crucial for the brain development and myelination in the central nervous system, and also influences gene involved in the bond formation and turnover. So ultimately, at the various levels, various kind of genes are activated by the T3, and they do the various changes like growth hormone synthesis or bond formation and turnover, and also for nervous system, myelin sheath preparation, etc., development, etc. Next, when cardiovascular genes are mainly activated. So at that time, these genes increases sensitivity to catecholamines and enhance the cardiac output and heart rate. They also enhance the calcium cycling in cardiac muscle cells and improve the cardiac contractibility. So on the heart, main effect of T3 is improving cardiac contractibility and enhancing the cardiac output and heart rate by the help of the genes. Next, let us see the metabolic effect. The genomic action of thyroid hormone mainly increase the basal metabolic rate by upregulating genes involved in the oxidation, phosphorylation, thermogenesis, and metabolism of carbohydrate, fat, and proteins. So the enzymes or proteins which are required for the oxidative phosphorylation or thermogenesis, they are mainly increased by the genomic action of thyroid hormone. We can see an example like increased expression of sodium potassium ATPases. This leads these changes. Next, there are also non-genomic effects because thyroid hormone can act at the nuclear level as well as at the cytoplasmic level. So when thyroid hormone act at the nuclear level, then it is called a genomic effect. And when thyroid hormone act on the other than the nuclear part, like the cytoplasm or cell membrane, then it is called non-genomic effect. So in non-genomic effect, it is mainly acting in the cytoplasm at the cell membrane within various organelles of the cell, like mitochondria. Next, thyroid hormone mainly acts as rapid and non-genomic effect by interacting with the protein, mainly at the site of plasma membrane or in the cytoplasm, which modulate the signal transduction pathway and ion channel activity. So the main effect of thyroid hormone on the plasma membrane or cytoplasm is modulation of the signal transduction and also modulation of the pathways and ion channel activities. So these three things are responsible for various activities. Next, T3 and T4 can bind to the integrin alpha V beta 3 receptor on the cell membrane. On each cell, there is specific receptors. They are known as integrin alpha V beta 3 receptor, which is involved in the cell adhesion and signaling. The main function of this receptor is cell adhesion and signaling. So the activation of this receptor by thyroid hormone when T3, T4 activate this integrin alpha V beta 3 receptor, they can stimulate the mitogen activated protein kinase signaling pathway, which promote the cell proliferation, angiogenesis, and survival of the cell. So this is the important for the cell survival as well as angiogenesis and proliferation of the cell. Next, thyroid hormone can also modulate the ion channels. So let us see the example of calcium channels. T3 mainly influence the activity of various ion channels, including voltage-gated calcium channels too. So the modulation of these channels can enhance the calcium entry into the cells. And when calcium enters inside the cell, they affect mainly in cardiac cells, cardiac muscle contraction, and also increase the overall heart function. Next, T3 can also increase the activity of sodium potassium ATPases pump on the cell membrane. So on the cell membrane, there are specific pump which are sodium potassium ATPases, and with the effect of T3, this ATPases activity can be increased, and when the activity is increased, it leads to the enhanced the cellular ATP consumption, and it increases the cellular metabolism. Next. T3 directly can enter in mitochondria and affect the mitochondrial DNA transcription and protein synthesis. So direct effect on mitochondria results in the protein synthesis. And ultimately, this condition results in the increased production of ATP and production of heat, which enhance the overall energy metabolism. Next, when T3 upregulate the expression of of uncoupling protein, which disrupts the proton gradient in mitochondria. This results in the heat production rather than ATP synthesis, contributing to thermogenesis. So here, when uncoupling proteins are mainly attached with T3, they only produce the ATP, but they do not contribute the heat production. Next. T3 also can activate the phosphoinositidine 3 kinase PI3K pathway, which leads to the activation of protein kinase B. And this pathway is involved in promoting cell growth, survival, and glucose metabolism. Next. T3 also activate protein kinase and it influences the cellular response and adaptations. Next. T3 also increase the activity of glucose transporter GLUT for receptors on the cell membrane. And this enhances the glucose uptake by the cells, especially in the muscles and adipose tissue, and supports in the energy production and storage. So this is a very important function of T3 because T3 can directly alter the glucose metabolism by affecting the GLUT4 receptors. Next. T3 can also affect the lipid metabolism. Mainly, it have effect on lipoprotein lipase and hormone sensitive lipase, and the activation of these enzymes results in increased lipolysis or breakdown of the fats and fatty acid oxidation, which provide energy and reduce the fat stores, which ultimately reduce the weight. Next. T3 increase heart rate and strength of the cardiac contraction when it modulates these ion channels and signaling pathway in cardiac cells. As we have discussed that T3 have effect on calcium channels. So when calcium entry occurs inside the cardiac cells, so it increase the cardiac output and also contractibility, and therefore it increase the heart rate. Next. At the cellular level, thyroid hormone are very critical and important for the normal growth and development, especially for the central nervous system during the fetal and early postnatal life. So the deficiency of thyroid hormone can lead to the developmental disorder such as cretinism. So when we are assessing the patient of thyroid related disorders, so we should keep in mind that in the case of pregnancy, we should be very serious while assessing the thyroid function. And if any pregnant lady have thyroid dysfunction or hypofunctioning of thyroid gland, which can lead a very serious effect on the child. Next. So in summary, let us conclude that what are the key elements required for the thyroid function. We have discussed that how thyroid hormones are synthesized, how they are transported, and what is the effect of thyroid hormone at the genomic level and non-genomic level. So at the various cells, there are different kind of actions occurs when T3 or T4 combines with the gene or specific cell receptors. So mainly required components for proper functioning of thyroid gland is iodine. So this is the essential for the synthesis of thyroid hormone, and the main source of iodine is iodized salt, seafood, dairy products, some plants grown in the iodine-rich soil. Tyrosine is also very important because it combines with the iodine to form the thyroid hormones, and it is also available in protein-rich food such as meat, dairy, nut, and beans. TSH stimulates the thyroid gland to produce and release T3 and T4, and it is regulated by thyroid releasing hormone, which is secreted from the hypothalamus and by the feedback from circulating thyroid hormones. Next. Selenium is also important component of deiodinase enzymes. The main function of deiodinase enzymes is to convert T4 into the T3, which is more active form. And selenium is mainly the source of selenium is Brazil nuts, seafood, meat, and grains. Zinc is necessary for the synthesis of thyroid releasing hormone in the hypothalamus and overall thyroid hormone metabolism. And the main source of zinc is meat, shellfish, uh, legumes, seeds, and nuts. Iron is the cofactor for thyroid peroxidase enzyme, the main enzyme involved in the iodination of tyrosine residue and thyroglobulin. As we have discussed that monoiodotyrosine and diiodotyrosine are mainly composed by the effect of this hormone thyroid peroxidase, and the iron is mainly required for thyroid peroxidase. So it is available from the red meat, beans, fortified cereals, and spinach. Vitamin A and vitamin D are also helpful in the functioning of thyroid gland. Next. So when thyroid hormone are not functioning properly, or when there is hypofunctioning of thyroid gland, so T3 and T4 level decreases in the body, and this condition produces specific cellular level changes and some manifestation of the body we can see. So what occurs when thyroid is hypofunctioning? So this condition is known as hypothyroidism. In hypothyroidism, mainly at the cellular level, what changes occurs? So low thyroid hormone level are there, which reduces transcription of the genes involved in the oxidative phosphorylation and thermogenesis, leading to the decreased ATP and heat production. When there is hypothyroidism, T3, T4 are less. So due to the low level of T3 and T4, the gene transcription reduces, and therefore the oxidative phosphorylation and thermogenesis process also uh, compromised, and which leads to the decrease in ATP and heat production. Therefore, there is decreased basal metabolic rate, and it can be seen as a weight gain, cold intolerance, and decreased sweating. Due to the low thyroid hormone, deficient thyroid hormone also lead to the decreased protein synthesis, affecting the muscle maintenance and repair. This can be seen as a reduced protein synthesis in the body, and it causes the muscle weakness, cramp, or myxedema in the severe swelling. Low thyroid hormone level can also reduce the lipolysis, leading to the increased level of serum cholesterol and triglyceride. So this can be seen as an impaired lipid metabolism, and which results mainly in the weight gain, hypercholesterolemia, increase the risk of atherosclerosis. Next. Low level of thyroid hormones also reduces gluconeogenesis and glycogenolysis process. So it mainly decreases the carbohydrate metabolism, and it can be seen as a hypoglycemia, fatigue, or lethargy. T3, T4 level, when it is low, it reduces the expression of adrenergic receptors, and it decreases the cardiac output. So we can see the cardiac manifestation like bradycardia, decreased exercise tolerance, and sometimes cardiomegaly. Low thyroid hormone level also impair the neuronal development and function. So neurological effects are seen, and it can be manifested as a depression, cognitive impairment, slowed reflexes, peripheral neuropathy are mainly seen in the hypothyroidism. The cellular level changes by the low level of T3 and T4. Next. So we can see that common symptoms of hypothyroidism are weight gain, cold intolerance, constipation, dry skin, fatigue, depression, hair thinning, hair loss, difficulty in concentration, menorrhagia, myalgias, arthralgias, weakness, memory impairment. So at various kind of cells in the body, at various systems, the T3 and T4 affect the cellular functions and produces such kind of symptoms. Next. Next. Some clinical sign and laboratory changes which are seen in the hypothyroidism are bradycardia, forced phases, cognitive impairment, delayed relaxation phase of the peak tendon reflexes, diastolic hypertension, edema, goiter, hypothermia, lateral eyebrow thinning, macroglossia, periorbital edema, pleural and pericardial effusion can be seen. And in ECG, the low voltage uh, cardiac ECG waves are seen. In laboratory investigations, elevated C-reactive protein is there, hyperprolactinemia, hyponatremia, increased creatinine kinase, increased VL, low density lipoprotein cholesterol, triglyceride may be increased, normocytic anemia will be there, and sometimes proteinuria may be seen in the hypothyroidism patients. Next. So clinical examination of the thyroid gland is very important. When patients having any sign and symptoms of thyroid gland, should be able to examine the thyroid gland, and we can examine it by the observation, palpation, and auscultation of the thyroid gland. So let us see one video. Next वीडियो आपकी ओर से प्ले शायद नहीं होगा, हो रहा है, चलो शायद हो जाए, इसको ऑन कर. Yes. So this video is from Stanford University uh, about examination of thyroid gland. So here you can see the palpation, how to palpate the thyroid gland. When there is a condition of thyroiditis or goiter, you can palpate the thyroid gland. Okay, next slide. Next slide. इसको क्लोज करके करना पड़ेगा शायद, ये दूसरी बार वीडियो प्ले हो रहा है. Yes. So after examining the thyroid gland, how to write or how to grade your findings. So when thyroid gland is not palpable or there is no visible goiter, so we can see as a grade 0. When it is palpable, then grade 1. So goiter detected only on palpation, then 1A. And if goiter is palpable and visible with neck extended, then we can give grade 2A. Grade 2 is mainly when goiter visible with neck in normal position, and when it is a large goiter visible from the distance without specific position, then we can say it a grade 3 thyroid. Next, investigation. So, what kind of investigation we can advise the patient, and what is the purpose of specific investigation, and how to interpret the findings? So, let us first important investigation is TSH, thyroid stimulating hormone. So, the main purpose of this investigation is primary screening test for the thyroid dysfunction. If high TSH is there, which indicates the primary hypothyroidism, and low TSH indicates the hyperthyroidism. or secondary or tertiary hypothyroidism. Free T4, which is known as thyroxine. The purpose of this investigation is to assess the thyroid hormone level in the circulation. Low free T4 indicates hypothyroidism, and high free T4 indicates the hyperthyroidism. Total T4 is mainly used to measure total thyroxine, both bound and free. So its interpretation is same to the free T4. Next. Free T3 is used to assess the active thyroid hormone level in the circulation. So low free T3 is mainly seen in the hypothyroidism, and high free T3 is seen in the hyperthyroidism. Same for the total T3. Another investigation which is very important, this is the TPO antibodies, thyroid peroxidase antibodies. This investigation is used to detect the autoimmune thyroid disease like Hashimoto's or Graves disease. So high level of TPO antibodies indicate that autoimmune thyroid disease is there, and which is mainly increased in Hashimoto's thyroiditis. TG antibodies, thyroglobulin antibodies, is used to detect the autoimmune thyroid disease. So TPO and TG antibodies are mainly used for the autoimmune condition of the thyroid disorder, and high level of TG antibodies also indicated the autoimmune thyroid disease, which is most common in Hashimoto's thyroiditis. One investigation is TSI, thyroid stimulating immunoglobulins. It is used to diagnose the Graves disease, and high TSI, thyroid stimulating immunoglobulin, indicate the Graves disease condition. Next. Thyroid ultrasound is used for evaluation of the thyroid size, structure, and nodules. So, hypoechoic areas while doing the ultrasound of thyroid glands indicates the thyroiditis or nodules. Further evaluation needed that it is benign or malignant. And increased vascularity is mainly seen in the Graves disease. So, thyroid ultrasound is also useful for diagnosing the Graves disease or some benign or malignant tumors. Radioactive iodine uptake and scanning is used for the assessment of thyroid function and differentiate various causes of hyperthyroidism. So, high uptake of radioactive iodine is mainly seen in the Graves disease or toxic multinodular goiter, and low uptake is mainly seen in the thyroiditis or iodine-induced hyperthyroidism. Another test is TRS stimulation test. So it is used for differentiating between the secondary and tertiary hypothyroidism. When this response is blunted, indicate the secondary, means pituitary related hypothyroidism, and normal TSH response indicate the tertiary level hypothyroidism. So when we want to differentiate that the hypothyroidism is primary, secondary, or tertiary, at that time TRH stimulation test is used. Next. Calcitonin is also used to diagnose the medullary thyroid cancer. So high level of calcitonin indicates the medullary thyroid cancer or C-cell hyperplasia, and thyroglobulin level is used to monitor the treatment of thyroid cancer. So high level of thyroglobulin indicate residual or recurrent thyroid cancer or post-thyroidectomy. Next. Yes. So this is the algorithm for evaluating the suspected hypothyroidism case. When we see any person having specific symptoms as we have discussed of hypothyroidism in the patient, so how to evaluate in systemic manner? So first, if any person has sign or symptoms of hypothyroidism, we have to advise the TSH. If TSH is normal, then patient having normal thyroid or patient is having euthyroid. If TSH is increased than normal, then you have to measure the serum pre-T4. If T4 is below normal range, then this condition is not primary hypothyroidism. If TSH is within normal range and TSH is high, then it is subclinical hypothyroidism. And when T4 is above normal range and TSH is also more than normal, so this is not primary hypothyroidism. You have to refer the case to the endocrinologist for the further investigations. When TSH is less than normal level, so we have to consider it a hyperthyroid state. Next, this is the simplest form that how to interpret the thyroid functions, mainly free thyroxine level and TSH level. So let us see from this side, if any person have low TSH level and low T4, so this is secondary hypothyroidism. When low TSH and normal T4, it is subclinical hyperthyroidism. When TSH is low and T4 is high, it is a primary hyperthyroidism. So you can easily understand by these boxes, and you can keep it in your OPD. So when interpreting the thyroid function with the help of T4 and TSH, you can easily diagnose that it is the condition of hypothyroidism or hyperthyroidism or uh, not any thyroid related illness. Next. Let us see about the treatment of hypothyroidism. The main goal of the treatment is to normalize the TSH level, regardless the cause of hypothyroidism. Whatever the cause is there, main aim is to normalize the TSH level. Treatment once daily dosing with levothyroxine sodium. So the main drug used for the treatment of uh, hypothyroidism is levothyroxine sodium, and the dose is 1.6 microgram per kg per day. So mainly a person, adult person having the weight of 60 kilograms, dose comes to 100 microgram per day. And while treatment, we have to monitor TSH level at 6 to 8 weeks after initiation of therapy. So after every 2 months, we have to monitor the TSH level, that whatever our target is achieving, the TSH level is being achieved or not. Next. Population specific dosing is also recommended for thyroid hormone replacement therapy. In non-pregnant patients, as we have discussed, the main dose is 1.6 microgram per kg per day, and we can increase the dose by 25 microgram daily every 6 weeks until TSH is normal. So we have to start with 100 microgram, and after 2 months, if the TSH is not normal, so we can increase 25 microgram again. In older patient, the dose should be kept minimal, so 25 or 50 microgram dose should be started, and after 2 months, we can start increase the 25 microgram of thyroxine. In pregnant patients, 2 extra doses are given in a week. So in a week, mainly normal person takes 7 doses, but in pregnant ladies, 9 doses are given. And the patient having subclinical hypothyroidism means TSH level is less than 10, then the dose is 50 microgram daily. And if the TSH is more than 10 unit, then it should be given a dose as we have discussed for the non-pregnant patient, like 1.6 microgram per kg per day. Next. Next. Those should be adjusted according to the age, severity, duration of the hypothyroidism, and concomitant drug therapy, pregnancy, and other disease present in the patient, specifically cardiac disease. Next. In cardiac condition, the dose should be given in alternative day. So the rule is that start low and go slow. So the patient who are having cardiac disease, so minimum dose should be started and slowly the dose should be increased up to the target. Next. How the effect of drug comes with the time. So when we start the treatment, levothyroxine, so patient feels better in 2 to 3 weeks, and reduction in the weight is the first improvement. Facial puffiness then starts coming down. Skin changes, hair changes take a longer time to regress, and TSS starts showing decrement from the high value, and TSS return to the normal eventually. So this is the effect of drug with the time. Next. Some drug can interfere with the action of levothyroxine. These drugs are rifampicin, carbamazepine, phenytoin, phenobarbital, amiodarone, sucralfate, ferrous sulfate, soybean formula, albumin hydroxide, cholesterol hydrochloride. So these drugs the patient is taking, so it should be keep in mind that patients should not take this drug along with the levothyroxine. Otherwise, we cannot get the desired effect of the drug used for the thyroid. dysfunction. Next, let us understand hypothyroidism according to Ayurveda. So in Ayurveda, there is not a direct correlation said we can say the hypothyroidism is this condition mentioned in Ayurveda, but mainly some specific physiological characteristic mentioned in Ayurveda can be correlated with the concept of metabolism and thyroid functioning. So the concept of Agni is mainly correlated with the thyroid functions. Next, in Ayurveda, we can say there are three types of next Agni, Jatragni, Dhatwagni, and Bhutagni. So, in the thyroid functioning, we have seen that uh, it is requirement of iodine for the proper functioning of or formation of thyroid hormones. So, Jatragni level function we can consider as the assimilation of iodines and synthesis of thyroid hormone in the thyroid follicles can be considered at the function of Dhatwagni level, and the effect of this T3 and T4 at the cellular level on the genomic level and effect through the mitochondria production of energy, this can be considered as the function of Bhutagni level. Next. Next, so this we have discussed how Jatragni, Dhatwagni, and Bhutagni can be understood with the uh, thyroid function. Next, next. Yes. Actually, Agni is a very broad concept, and mainly Agni, it's work by the Ahar Parinamkar Bhava. So, how we can integrate the Ayurvedic concept with of Ahar Parinamkar Bhava with thyroid function can help to treat the patient. So, Usma, Vayu, Kleda, Sneh, Kal, and Samyog. These six are the Ahar Parinamkar Bhava, and they represent the Agni. So R is not just the food or diet what we are taking. Yes, there are, but dhatva hi dhatva ahara samruddha. So ras is ahar for rakta, rakta is ahar for mans, etc. So this ahar pranamkar bhava concept is also can be expanded to the cellular level as well as tissue level for the understanding the thyroid functioning. USMA can be considered as the enzymes of mitochondria, and the main function of these enzymes is metabolism. And the enzymes like deiodinase, Di1, Di2, Di3 involved in the conversion of T4 to T3 and regulation of metabolic rate can be considered as a USMA. Vayu is responsible for movement and controlling of the body functions. So TRH, TSH, T3 and T4, they can be considered as a molecule of Vayu. They are signaling for the metabolism. Clay is considered as a water. This is important for the transportation of iodine. Snail can be considered as lipids, cholesterol or lipoproteins, and it is useful for transportation of the thyroid hormones from thyroid gland to the cellular level. Kal, circadian cycle is responsible for regulation of hormone, and samyog combination means homeostasis of all above substance are required for the proper functioning of the thyroid gland. So the Usma, Vayu, Clade, Sneh and Kal, if any one of these, one or more are disrupted, then they can disrupt the function of thyroid gland. And accordingly, we have to find out the exact thing that Usma among these six parameters, which one is functioning not well. And accordingly, if we correct it, then we can correct the thyroid function. Next. According to dosa, if we want to understand thyroid gland, so the function of TRS, thyroid releasing hormone, and TSH, thyroid stimulating hormone, can be considered the function of pranavayu because it initiates and regulates the thyroid hormone production. The T3 and T4, uh, release of T3 and T4 and their action on cellular level can be considered as the function of Udan Vayu, which represent the release and action of thyroid hormones. Circulation of thyroid hormone can be contributed by the Vyan Vayu. Assimilation of iodine occurs by the Saman Vayu. Excretion of metabolic waste is mainly by Apanvayu, and catabolic enzymes is mainly correlated with pitta, and anabolic enzymes can be correlated with kapha. Next. So according to the symptoms of hypothyroidism, we can see the dose dominancy, like weight gain, cough, vritti. These are the references. So if we analyze these symptoms, so main dose involvement is kapha vritti, pitta kshay, and vata vritti. Next. According to the involvement of dhatu, if Ras dhatu is involved, Ras dhatu agni is not functioning properly. So the symptoms may be weight gain, loss of appetite, heaviness of body, lethargic, cold intolerance, menstrual disturbance, generalized achy, puffiness, premature aging symptoms like hair loss, anemia, infertility. So according to various dhatu involvement, we can see the various kind of clinical features of hypothyroidism. So while treating cases of hypothyroidism, according to Ayurveda, we have to find out the involvement of specific dhatu and target that particular agni for correcting the underlying pathology of hypothyroidism. Next. These are the srotas involved in the pathology of hypothyroidism and its manifestation in the patient. Like in if there is uh, not proper functioning of anvas srotas, then patient may have loss of appetite or malabsorption of foods. Rasva srotas if involved, then weight gain, loss of appetite, lethargy, such kind of symptoms may be there. In Mansva, there will be edema or Galgan. So these all symptoms of hypothyroidism can be categorized according to the Srotas involvement. Next. These are the Samprapti Ghatak, mainly the Jatragni, Tatvagni are involved, and Rasva Srotas and Medava Srotas mainly seen in the patients. Sang, Vimargaman type, and Siragranthi type of pathology is mainly seen. Next. Yes. So, what should be the treatment plan according to Ayurveda? I have tried to make a plan like considering the Aturbal and Vyadhibal. So, Vyadhibal can be assessed by the TSH and T4 level. So, if any person have a overbal, Aturbal is over and disease bal, and it means T4 is normal and TSH is high, mainly up to 10. So in that condition, Nidan Parivartan is sufficient. If Aturbal is very less and T4 mildly reduced and TSH high 10 to 20, then Nidan Parivartan along with Agnidipan is required. When Aturbal is over and T4 is moderately reduced, TSH between 20 to 30. So in this condition, Nidan Parivartan, Agnidipan as well as Rasayan therapy is required. And when patient have overbal and T4 is severely reduced, means and TSH is more than 30. In that condition, Nidan Parivartan along with Agnidipan, Rasayan and integrative approach is required. Low dose of thyroxine should be given. So it can help patient to recover very fast, and we can also prevent the complications. If patient have Madhyam Aturbal, so Nidan Parivartan along with seriousness of the condition, we can advise Mrudu Homan and Viresan along with Agnidipan. And when severity of the disease is more than frequently Mrudu Shodhan and Agnidipan should be done. So same for the Praverbal. In Praverbal, the frequency of Shodhan can be increased. So if in Madhyam we have advised the patient, we can advise patient Shodhan once in 6 months, or in Pravar Agnibal, we can advise quarterly Shodhan. And according to the severity of disease, we can advise Rasayan or Kalp of the various Rasayan drugs. Next. According to the involvement of Srotas and specific symptoms of hypothyroidism, the specific treatment like if Anva Srotas is involved and there is loss of appetite or there is not proper absorption of food, digested food, then Chitrakadi Vati or Sanjivani Vati can be advised. If patient have weight gain, loss of appetite, lethargy, generalized body ache, heaviness in the body, puffiness. So in this condition, Trikatu Churna, Panchakol Churna or Sadushan Churna can be given. If there is a involvement of Raktava Srotas and due to that there is a loss of appetite, weakness, lethargy, slowing of mental activity or anemia, so Navaya slow and Pidangani low is the choice of drug. In Manswa Srotas involvement, if there is edema or Galgan, so Kanchnar Guglu is the choice of drug. If Medova Srotas is involved and tiredness, sleepiness, sluggishness, hyperlipidemia is there, so Arogya Vardhini Bhati is the choice of drug. Astiva Srotas is involved and there is osteoarthritis and hair loss. So Panchamrit Kalpati Laksadi Guglu can be given. In the osteoarthritis and osteoporosis condition, when Majjava Srotas is involved, so Tapyadilo and Silajitwadilo is the choice of drug. Uh, when Sukrava Srotas is involved and patient have loss of libido, infertility, so the Silajitu Rasayan or Pipli Rasayan is useful. In the condition of involvement of Svedava Srotas, when patient have minimal sweating or absent of perspiration or dry and coarse skin, so Sanjeevani Bhatti and Varun Sigrukvat should be given. When patient have constipation, so Gomutra Haritaki in obese case is the choice of drug. And Artava Srotas involvement is there, then at that time Kumaryasra or Kanyal Vadivati can be given. Next. So when we are having special cases like hypothyroidism is due to the autoimmune condition. So in autoimmune condition, the rasayan kalp like Vardhman PPA rasayan and gold preparation like Swarna Sutsekar Ras or Vasant Malini Ras or Lakshmi Vilas Ras should be the choice of drug. We can also advise Silajitu rasayan. So gold is the best for autoimmune condition and specific rasayan should be adopted after proper sodhan if possible patient have good bulk. In Galgand condition, Sodhan, Shastra Karma, and Ksar Karma is the treatment principle. So, according to the condition, we have to advise surgery or we can perform Ksar Karma or we can advise the Sodhan, Vaman or Virechan, etc. And the drugs like Kanchnar, Guglu, Varunadi Kasai, Gandamala, Kandandas can be given. Next. Yes. So, here is a compilation of some evidences, some researches. In that it has been found that Ayurvedic drugs are found effective on thyroid function. First drug is Dami. So the leaf extract of the Dami increases T4 concentration without enhancing the hepatic lipid peroxidation. And there is no effect of Brahmi on T3, but it increases the T4 level. Punjika oil prevent the hypothyroid associated learning and memory impairment. It is neuroprotective and regulates estradiol and prolactin level. So it can be given in the patient of hypothyroidism who have the memory impairment or cognitive issues. Haridra is Haridra improves the expression of SOD in brain region and reduce the lipid peroxidation, which modulate the antioxidant defense system, and therefore Haridra is the choice of drug in the autoimmune hypothyroidism. Amra, Irvaru, and Kalindi. These three drugs restore the serum T3 and T4 level and diminish the tissue level peroxidation when used individually. So they can also be a choice of drug in the hypothyroidism. Next. Varun extract increase free T4 and also decrease TSH level. It also promotes the peripheral conversion of T4 to T3 and retain the iodothyronine deiodinase activity. So Varun is also good choice for hypothyroidism drug, hypothyroidism treatment. Ashwagandha extract restored the serum T3 and T4 level in the diabetic mice model, and it counteracted dexamethasone-induced hypothyroidism. So if drug-induced hypothyroidism, specifically steroid-induced hypothyroidism cases are there, then ashwagandha can be a choice of drug. Povida have a similar effect to the ashwagandha. Kachnar improves the thyroid function, thyroidal weight, and iodine 131 uptake, and it also decreases the serum cholesterol. Next. Chalkundi enhance the thyroid hormone release, and its effects are comparable or similar to the Kachnar. Guglu increase T3 concentration, it also enhances thyroidal weight and iodine 131 uptake. Apamar leaf extract increase T3 and T4 level, increase blood glucose. Pushed stimulate thyroid function, and these evidence are mainly based on thyroidal histology. So effect of pushed is on thyroid histology is also noted. Pushkarmol have similar effect to the pushed, Sigru increase T3 and T4 levels and also decrease the TSH levels. So it is also a good drug for the hypothyroidism. Falgu have also increase serum T3 and T4 level. Next. So while treating the cases of hypothyroidism, we should keep the special population in the mind because this population requires specific consideration, like older patients, the patients who are having a ischemic heart disease or they are suspected to have a ischemic heart disease, pregnant women, and patients with persistent symptoms of hypothyroidism despite taking adequate doses of levothyroxine. So, in spite of taking the medication, and patient is not having normal thyroid function, then we should consider them a special population. Patient having subclinical hypothyroidism, they must be monitored for a long time. So they are also a special population. And patient suspected having a myxedema coma, they are also a special population, and it needs a careful consideration while dealing with them. Next. Sometimes patient is taking medicine previously with medicine the patient have normal thyroid function, but after few time patients may have not uh, effect of drug on normalizing the TSH levels. So what are the factors can be the responsible for that? So if patient is not adherent to thyroid hormone regime, if patient is missing the dose, then previously stable patient can have a abnormal thyroid function. Another thing is decreased absorption of the thyroid hormone. Patient is now taking thyroid hormone with food. So when any person take the thyroid levothyroxine with the food, then the effect of drug becomes less. When patient take the thyroid hormone with 4 hours of calcium, iron, or soya products, then it also interfere with the thyroid hormone functioning. Some products, aluminium containing antacids, also interfere with the thyroid uh, hormones. And when patient is prescribed medication that decrease the absorption of thyroid hormones such as cholecysteramine, cholesterol, orlistate, and sucralfate, they also decrease the efficacy of the thyroid, levothyroxine or thyroid hormone. Next. If patient is pregnant or recently started or stopped estrogen containing oral contraceptive, so they can also have effect on thyroid hormone functioning. Generic substitution for brand name can also have similar effect. If patient have started sertraline, another selective serotonin reuptake inhibitor or tricyclic antidepressant kind of drug, or carbamazepine or phenytoin. So these drugs can also have some effect with the thyroid hormone and can reduce the efficacy of thyroxine. Next. So what the mind knows, the eye see. Whatever things in our mind, we can see. So when any person having specific such kind of symptoms, we have to advise TSH alone for the screening purpose. So any person having the psychiatric symptoms, we should think that there may be thyroid dysfunctioning, and we should advise TSH for the screening purpose. Elderly women and men, hypercholesterolemia, lithium or amiodarone medicine if patient is taking, postpartum women, if any patient having amenorrhea, oligomenorrhea, menorrhagia, other autoimmune diseases are there, family history of thyroid disease, neck radiation therapy, previous treatment with thyrotoxicosis, autoimmune thyroiditis, infertility, decreased libido, and galactorrhea. If any kind of symptoms is there, we should suspect that there may be some thyroid dysfunction and advise the TSS. Then we have to screen or advise other investigations if required. Next. So these are the references for the further reading. So you can go through the various articles. Next. This is the list of the reference. Thank you. थोड़ा लंबा लेक्चर हो गया कुछ टेक्नोलॉजिकल डिस्टरबेंस की वजह से भी. If anyone have any query, you can ask.
Thank you, Dr. Bharat,
for sharing your views and experience about hypothyroidism, Ayurvedic and modern perspective. I am quite sure that today's presentation would be most useful in betterment of clinical efficiency of all of us while approaching a patient of hypothyroidism. On behalf of Kai Chikitsa Department, ITR Jamnagar, we are very much thankful to you for the time and effort you took for this presentation. Thank you once again. And with this, let us move to question and answer session. As Dr. Bharat Padar has told that any question or queries are there, they are most welcome. Participants are welcome for the queries and questions. As we all know that questions and the discussions are meant to be a part of gaining knowledge, especially when we have such an expert in the field of Ayurveda with us today. So I think students who have joined us today as a participant, they have to take benefit of this opportunity. If you have any queries regarding the subject, you are free to ask. Any scholars from the ITRA? Because sir has very nicely elaborated, starting from the anatomy, pathophysiology, the physical examination, and Ayurvedic perspective to correlate the hypothyroid and other conditions. So it is a chance to have the solutions of our questions. So I think no one has any queries. Dr. Bharat?
1.5 घंटा हो गया, अब मैं नहीं कर सकती है, ओवर टाइम ले लिया मैंने.
Okay, so thank you once again for such a nice presentation. And before we end this webinar, I would like to express profound gratitude to Honorable Director ITRA Jamnagar and our respected head of the department, Professor Mandip Goyal ma'am, for their constant and valuable support and guidance throughout the journey of this webinar series. I must mention deep sense of appreciation to all the staff, faculties, and MD PhD scholars of the Kai Chikitsa department for joining hand together in planning and making this event successful. At the last but not least, we are very much thankful to all participants for joining this webinar today and hope to see you in future events also. So I think someone has raised the hand. Just a minute. Okay, so by winding this webinar, thank you once again, Dr. Bharat Padar, for accepting our invitation for today's guest speaker and being with us today. So thanking you all. We'll be meeting soon with the next episode, that is 10th episode of Kayaprabodhini webinar series, organized by Department of Kai Chikitsa, ITR Jamnagar. Till then, goodbye everyone. Namaste.